Bismillahirrahmanirrahim. This presentation is regarding the femur bone. Femur is the largest bone. It's about 18 inches in length. We'll discuss about the head of the femur, the neck, shaft, and the lower end of the femur. And then we'll go on over to some of the clinical anatomical features of the femur related to fractured neck femur, related to avascular necrosis, fractured shaft femur, fracture proximal and mid shaft, and fracture distal end of femur, and Perthes disease, and coxa vera and coxa valgus. Now, to start with, I'll come to the anterior aspect of the right femur. So the femur has got the head of the femur, which articulates with the hip joint, acetabulum. It has got a neck and a junction between the neck and the shaft, which is above is the greater trochanter, more lower down and posteriorly is the lesser trochanter, and in between is the intertrochanteric line. And then you've got the shaft and the lower end, which have got condyles. Now, there is an angle between the neck and the shaft of the femur. This is the angle of inclination. And I'll talk about the number one about the head. Let me show you the head over here. This is the head of the femur, and there is an articular cartilage over here. There is a depression in the center, which is fovea, central fovea, where there is an attachment of ligamentum teres. And this ligamentum teres carries a blood supply for the head of the femur. And this is the epiphyseal plate. And then you got the neck, greater trochanter, intertrochanteric line, and lesser trochanter. So in the head, there can be slip epiphyseal plate. And if this becomes disturbed, there may be compromised blood supply to the head. And if this is not detected, the head will not get the blood supply and will undergo necrosis, will die off. That is known as avascular necrosis. So the head is very important by way of blood supply. This is the head of the femur. There is a central fovea where the ligamentum teres is attached, and this carries a blood vessel. The blood vessels also come from the diaphysis and supply the neck. And the blood vessels also come from the capsules, which are known as capsula reticula. and they supply the neck and the head. So the blood supply of the neck and the head is very important. There are three sources. Number one, coming from the diaphysis. Number two, coming from the capsules. And number three, coming by way of ligamentum teres. Now I'll show you the importance of this when we are talking of fracture neck femur. So that's the anterior surface of the femur, intertrochanteric line, neck, greater tubercle, greater trochanter, lesser trochanter, and this ends up into two condyles, a medial condyle over here and a lateral condyle over here. And there are two epicondyles, and on the medial epicondyle there is an adductor tubercle. And there is an articular surface anteriorly which articulates with the patella. Now we come to the posterior aspect of the femur. Now in the posterior aspect, again, most prominent is the greater trochanter. Lesser trochanter is well seen posteriorly, and in between there is an intertrochanteric crest. That's the neck and that's the head. Posterior aspect of the shaft has got a crest here which is known as linea aspera. Linea aspera. And this linea aspera divides lower down posteriorly, medially and laterally. The medial lower down has got a adductor tubercle, and that is the lateral line going to the lateral and medial condyle. And in between two there is a deep intercondylar fossa. There is a deep intercondylar fossa where you get attachment of the cruciate ligament. So that's the description, gross description of the head, neck, shaft and lower end anteriorly and posteriorly. Now we come to the important clinical aspect, that is the fracture neck femur. Fracture neck femur is very common in elderly patients. And the fracture can be between the two trunca, greater trochanter and lesser trunca. This is known as the intertrochanteric fracture or pertrochanteric fracture, where the shaft separates from the neck completely. In proper neck, the fracture can be subcapital, just beneath the head, subcapital. It can be cervical, in the mid-neck part of the neck, or it could be basal, near the intertrochanteric line. Now what is importance of these different fractures? Look at this blood supply which I have told you earlier on. There is blood supply is coming from the ligamentum teres to the head, and the blood supply is coming from the shaft, and the blood supply is coming from the capsule. Now if there is a neck fracture, like what you call subcapital, If there is a subcapital fracture, or if there is a proper neck fracture or a basal neck fracture, what will happen? The blood supply which is coming from these two parts, capsular and shaft, they will be cut off and not supplying the head, whereas the blood supply through the ligamentum teres will be intact. But this blood supply is not sufficient for the neck and for the head. So in such a fracture, there is going to be avascular necrosis of the head. But if the fracture occurs over here, intertrochanteric fracture, this is intertrochanteric fracture, the blood supply will remain intact. It's coming from the capsule. Only the part which is coming from the diaphysis is cut off, whereas the blood supply from these two parts, ligamentum teres and from the capsule, is intact. So there is no chance of avascular necrosis here. So when you are deciding for treatment, surgical treatment for the neck of the femur, you take this into account. What type of fracture is it? Is it a cervical neck fracture, or is it a fracture which is involving the intertrochanteric line? And then you decide what to do. So that was the important part in the neck. Now we come to the shaft. Now the shaft can be fractured either proximally, or it can be fractured in the mid region, mid shaft. So there are two segments now. One is the proximal segment and the other one is the distal segments. Now the proximal segments, the muscles which are acting is iliacus and psoas major, which will cause flexion, and there will be abduction of the pigmentus medius and minimus. So this proximal part will go by way of abduction outside. Then the distal half of the shaft which is fractured, there is pool of adductors, so it will go medially. And because of the spasm of the muscles, the two ends can ride over each other. So whenever a fracture of the mid shaft or proximal shaft happens, you got two segments, one which is proximal and one which is distal, and each one of is acting differently. The above is going towards abduction and flexion. The distal half is going into the adduction, and there is overriding. So you have to reduce these flexures and bring the two things in alignment, and it requires a lot of force. Now what happens in fracture where is distal fracture, distal end of the fracture? Now this is the condyle of the femur and this is the distal fracture, just about the condyle of the femur. Now here gastrocnemius muscle is attached, very powerful muscle, and this will cause pulling down of the gastrocnemius. And here is the popliteal artery in the popliteal fossa. So popliteal artery can be dangerous. So this is a very dangerous fracture. Fortunately, this is very rare. Now I come to angulation of the neck with the shaft. The normal angulation in a child is 160 degree. Normal angulation in male is 125 degree. It is slightly decreased in female because of the broader pelvic uh, bones. Now in coxa vera, the angle between the neck of the femur and the shaft is decreasing angle of inclination. And this happens in slipped femoral epiphysis or wherever there is adduction fractures. In coxa valga, there is increased angle of inclination between the neck and the shaft. This is very rare, and this can happen in abduction fracture. Remember, in a normal child, the angle of inclination is about 160 degree. Now I've taken this X-ray of the hip joint. This is a young child. Epiphysis is not yet united. Look at the epiphysis. That's the ilium, acetabulum. This is the head, not yet united with the neck. There is the epiphyseal plate. This is the neck, and that's the greater trochanter, and that's the shaft. Now look at here. This is a young child. Look at this head and this head. Here the head is rarefied, not very dense. It's irregular. There are lucent areas. So this head is undergoing necrosis. It's dying it out slowly. Now this happens in slipped epiphysis of the head. That is epiphysis. This can slip off due to trauma or due to some other cause. And this will cause necrosis of the bone because the blood supply is cutting off. And that's known as avascular necrosis of the femur. So to summarize, we have got the parts of the femur are head, neck. The neck with the junction is the shaft, and the junction is lined by the intertrochanteric line anteriorly and intertrochanteric crest posteriorly. And between the two, between the intertrochanteric line and intertrochanteric crest, you got greater trochanter above and lesser trochanter below. Shaft, and then you got two condyles over here, lateral condyle, medial condyle, and articular surface of the patella. Posteriorly, you got a very well-formed crest, intertrochanteric crest, and a crest which is known as linea aspera, dividing posteriorly into a triangle, medial and lateral. Medial one has got intercondylar adductor tubercle, and in between the two condyle there is a deep intercondylar fossa where the cruciate ligaments which I have discussed in knee joint are attached. Then the important blood supply, three vessels supplying the neck and femur, ligamentum teres, carrying a vessel, capsular vessels by way of capsular reticula and coming from the shaft. And if the fracture is subcapital all cervical or basal, these arteries are going to be cut off, and the remaining artery would be coming from ligamentum teres, which is not sufficient to supply the neck and the head, and it will cause avascular necrosis. So that's the slip epiphyseal uh, of the this is the epiphysis, and that's the head, which I've shown you over here in the X-ray of a child. You can see it very easily. That's the epiphysis, and that's the head. And if this slip, you can get avascular necrosis. And then you got uh, angulation. Normal angulation is 125 degree, but in a child it's 160 degree. If the angulation is decreased, that is known as coxa vera. If the angulation is increased, that is known as coxa valga. Coxa vera happens in slipped femoral epiphysis and in adduction fracture, whereas coxa valga, which is increased angulation, that is rare, and it usually is in abduction fracture. So I stop here. I hope you found this useful. Thank you.